Hello, everyone. My name is John McAlevey, and I'd like to welcome you to the North American Spinal Cord Injury Consortium's member SCI Connections meeting. Connections is a quarterly online communication with the SCI community, again hosted by NASCIC. Our topic today is autonomic dysreflexia, and our guest presenter is the esteemed Dr. Stephen Kirschblum. Before we get the festivities going, however, Barry Monroe, treasurer of NASCIC, whom you will be hearing from shortly, asked me to tell you a little bit about myself and how AD has affected me over the years. On August 19, 1992, I had a fall down my basement steps and had a spinal cord injury at the cervical 3-4 level. Only that, it came along with a central cord syndrome diagnosis. And for those of you unfamiliar with central cord syndrome, it basically means that my upper body, arms, hands, fingers, and fine motor skills just don't work anymore. My doctors told me early on to think of myself as an upside down paraplegic. They knew that I would walk, but that I would have little to no use of my upper body, and they were pretty much spot on. I've been kidding with folks for years, telling them that I can get up and walk anywhere that I want to go. I just can't do anything once I get there. All kidding aside, over the years, my 32 years now living with spinal cord injury, I've been very active, from coaching basketball for over 22 years to now working as the peer mentoring coordinator at Kessler Institute for Rehabilitation in West Orange, New Jersey. And on top of that, in the middle of the COVID lockdown, I launched the Quadcast, a podcast that, although mainly for and about folks like me and many of you here that have been affected by a spinal cord injury, is really for anyone who just wants to be inspired. To date, I have over 65 episodes in the books, all of which can be found at www.quadcast.org. And now, as for a few examples of how AD has affected me over the years, I know that sometimes when my bladder gets distended and overfull, I get very sweaty quickly and get nasty throbbing headaches. So I have to make sure that I take care of that. And then also in the summertime, I don't do well in the heat. So when it gets very, very warm, I have to be careful because my blood pressure drops precipitously. And that's just a couple of examples, and I'm looking forward to hearing about how to handle things like that in our presentation. So now I would like to hand the microphone off to the aforementioned Barry Monroe, treasurer of NASCIC, for some words on the consortium and an overview of how today's presentation will proceed. Barry, the floor is yours.
Thanks, John. And thank you so much for agreeing to host our quarterly SCI Connections meeting. Just going on to the next slide, please. I just want to let everybody know that what we're doing today is I'm going to introduce and explain a little bit about NASCIC and who we are, and then John's going to go back and introduce our esteemed speaker and offer a presentation on AD. And of course, as always, we'll entertain questions at the end of the presentation. Next slide, please. So for those that don't know, the North American SCI Consortium was formed in 2018, and it was really a product of our community coming together and deciding that we really didn't have a voice when it came to all things in SCI research, and both in the cure setting and the care setting, and how we move forward. So the great news is that we came together and we more or less operate like an umbrella organization, inviting all the community groups throughout all of North America to join together on common ground. And what we did was we've got to the point where we have over 60 community-led organizations. So that includes our United Spinal Friends, and then there's several chapters, PVA and their chapters, SCI Canada and their chapters, as well as Christopher Dana Reeve Foundation, Miami Project, and others. And of course, Praxis, Spinal Cord Institute as well. All of these organizations really got behind this in the beginning, and we moved forward. But we also believe that in order to be a true all-encompassing organization, that we had to include also individuals who I call free agents. There's over 336 people who frankly might not be affiliated with any organization, but they have spinal cord injuries and they've expressed an interest in what we do. And then of course, there's 116 partner organizations, which includes industry, academia, and any other outside of the traditional membership that I just mentioned. So frankly, the whole enterprise of spinal cord injury is together under the NASCIC umbrella. And the mission is simple: to bring about unified achievements in research, care, and cure, and policy by supporting collaborative efforts across the spinal cord injury community. But more importantly, to achieve this mission, we have to identify the gaps, communicate the resources, and be a conduit of collaboration between community of people living with spinal cord injury and our many stakeholders. And what we're saying is, in many ways, like today, we're bringing together ideas, friends and family in our little world all across North America, and sharing great information that we can take back and use on the ground to help our local membership. And speaking of membership, go to the next slide, please, Jared. Anybody can join NASCIC, and we are encouraging you to do so. There's a QR code there, but frankly, go to North American SCI Consortium.org, and you will be able to download the opportunity to join. It's free. You get a monthly newsletter that nobody else gets, and a chance to kind of understand what's coming up and various resources that we bring to the table. And frankly, the resources that we do, we create resources like this today. We've created the SCI Research Advocacy course, which we encourage people to take. But we also share the resources of so many of our partners. And because we believe that collectively we have a lot of information that can be brought together and brought to all of us so that we can understand and maybe learn from each other and best practices and how we can improve the quality of living with spinal cord injury. With that all said, enough about us. We want to hear from the great doctor and you, John. So back to you. Thanks.
Okay, great. So why don't we get the show on the road? When I reached out for Dr. Kirschblum to see if he could shoot me over a bio, he sent me, I'm assuming, the Reader's Digest version, because had he sent me the full one, we would all celebrate a birthday by the time I got to the end of it. So here goes. Dr. Stephen Kirschblum is the Chief Medical Officer for Kessler Institute for Rehabilitation, Professor and Chair of the Department of Physical Medicine and Rehabilitation at Rutgers, New Jersey Medical School, and the Chief Medical Officer for Kessler Foundation. He served as the Program Director of the Spinal Cord Injury Medicine Fellowship since 1996, is the co-director of the Northern New Jersey Spinal Cord Injury Model Systems since the late 1990s, and the co-director for the Center for Spinal Stimulation at Kessler Foundation. On top of that, he has been my doctor for all these years, is my colleague today, and most importantly, dear friend. Ladies and gentlemen, I present to you Dr. Stephen Kirschblum.
John, thank you so much. And it really is a pleasure to be here. I think if I can just share my slides, someone else is sharing. So if you can unshare and then I can share, that'll be perfect. Thank you so much. Okay, so hopefully you can see my slides. Does it come out okay? Okay, then I got the thumbs up. Really is great to be here. I'm going to try to, autonomic dysreflexia is a diagnosis that I think that many people are aware of. And I really wanted to try to dig a little deeper in terms of what AD is, the causes, how to identify it, how to treat it, long-term complications, and maybe even get into a little bit about the future for certain types of treatments, and then really have a chance to talk about your questions and try to give answers. There are so many questions. When I originally put together this talk, it was about an hour and 20 minutes. And I said, no, I don't think that's going to work for this group, especially since I was told keep it to a half hour, 35 minutes max. So let's see where we go. So the definition of autonomic dysreflexia is really an exaggerated increase in blood pressure in people with spinal cord injury that's due to some sort of stimulus below the level of injury. Now, we use that term noxious, but noxious really can mean any kind of stimulation that normally is handled, but in this case, it can't be because of the injury. The specific quantification of dysreflexia is an elevation of systolic blood pressure of more than 20 millimeters of mercury above their baseline. And that's really important because many people with spinal cord injury have a lower blood pressure than they may before their injury. It's called chronic hypotension. So while the normal blood pressure for people may be 120/80, it's not unusual for people with spinal cord injury, especially with cervical level injury, to have blood pressures running lower, 80 to 90 millimeters of mercury for systolic blood pressure. So even a blood pressure of 110 or 120 technically meets the diagnosis of autonomic dysreflexia. It really can be an emergency. Now, I'm not saying that every episode of dysreflexia is severe and is going to cause a major problem, but we can't ignore it because it's a warning sign. And there are cases of where continued episodes of dysreflexia can cause seizures or hemorrhages or heart attacks or even death. Now, it usually occurs in people with injuries above T6. Now, why above T6? Because what happens is that the sympathetic nervous system runs through our spinal cord from T1, which is the first thoracic nerve, down to L2. But it's from T7 and below that the major sympathetic innervation to the gut and to the lower extremities come from. So if there's an injury above T6, that is when the body really can't shut it off. And I will show you specifically how that works. The more severe the injury, the greater the chance of developing dysreflexia. The higher the level of injury, so too the greater the chance. It will not occur in the first couple of days or even first couple of weeks after spinal cord injury. And most people that will develop dysreflexia will develop it in that first year. However, some people can still develop it even years after injury. The most common cause of developing dysreflexia is bladder. I would say that about 80% of all cases are due to the bladder. Bowel is the next most common. And then everything else is listed in the bucket as to what else can be causing dysreflexia. It could be pressure injuries, ingrown toenails, fractures. All the things that are listed there are really important. Now, it's important to differentiate signs and symptoms. So the signs of autonomic dysreflexia, or AD, is hypertension. It can go, as we mentioned, 20 millimeters of mercury above baseline. So if the person's normal baseline blood pressure is 90, even a blood pressure of 120 can be considered dysreflexia. But there are other cases, and you probably know better than most, there are cases that can go 150, 190, 220, 250. In my own experience, the highest blood pressure I've ever been consulted on a patient was a person whose blood pressure was over 300 millimeters of mercury of a systolic blood pressure. That's high. That made me nervous, and I try not to get nervous too often. Classically, you'll see reflex bradycardia, and I'll explain that in a moment. But interestingly, more commonly, you're going to see tachycardia. The heart rate will race faster than it normally will be. We have cases, I've seen patients, people that go into atrial fibrillation where the heart starts to fibrillate whenever the person's in dysreflexia. And then once you treat the dysreflexia, the fibrillation will go away. I've had one person with atrial flutter, but thankfully I've never seen a patient with ventricular fibrillation, but it has been reported in the literature. And then you have these other symptoms. So interestingly, I saw a patient today who came to me. It was the first time I saw the patient because another doctor was away. And they said to me, "Doc, lately I've been getting these red blotches on my neck. What do you think it will be?" And then, of course, I asked them, "What was your blood pressure at that time?" They said, "Oh, yeah, I was dysreflexic." Very common that there'll be a subtle U to the neck when a person becomes dysreflexic. The most common symptoms is headache. Not everyone develops a headache, but some people will develop a really severe headache. And some people will describe it as the worst headache of their life. People oftentimes will become anxious. I would become anxious too if my blood pressure was really sky high. But there seems to be not only a emotional anxiety, but a autonomic nervous system anxiety that occurs because the autonomic nervous system is going haywire. You'll also see some changes, pupil changes, nasal congestion. You can get very stuffy. Now, why does this happen? And there's a couple of pictures, but I wanted to show you something. And this was developed by Ryan Solinsky, who is one of my former trainees. I'm so proud of him. He has now become one of the leading experts in autonomic dysreflexia in this country, and I believe around the world. And so I want to try to explain to you how these things occur. So let's take a person who doesn't have a spinal cord injury, and this is their bladder and their spinal cord. When the bladder starts to fill with some urine, it will start sending information completely unconsciously up to the brain. The brain, when it has that, senses, oh, okay, you have a little bit of urine in your brain. But okay, don't worry about it because Dr. Kirschbaum just started his lecture. You can hold it in a little bit, and it will send information right back down to the spinal cord, and it will shut off the sympathetic fibers. It's sympathetic fibers within the bladder that start releasing information and chemicals so that the brain will be aware. And what the brain does is it shuts them off. So this works very well. But if a person has a spinal cord injury where there's no longer that connection, where the information can't go across the lesion to let the brain know that it's filled, and also on the opposite end to shut it off, here's what happens. The bladder still starts to get the sensation and tries to get the information up to the brain, but nothing shuts it off. So the bladder starts going haywire, trying to give the messages to the brain, but it never gets through. So the amount of sympathetic discharge that occurs from these nerves are unstoppable. And this is a problem. Now, this picture shows you very similar to what's happening. Your bladder starts to fill. The information can't go through since that sympathetic nervous system and discharge is going haywire. All these chemicals now cause the blood vessels in the body to contract and constrict. And when the blood vessels constrict, your blood pressure starts to rise. And unless you do something about it, it will continue to rise. So what happens is that ultimately it gets up, goes through the parts of the neck. We have blood vessels in our neck that read that the blood pressure is sky high and alerts the brain indirectly that blood pressure is high. But the brain can't send information back down to shut it off. So it does the next best thing. If you can't control the sympathetic nervous system and shut it off, activate the parasympathetic nervous system, which is believed to act sort of opposite of the sympathetic nervous system. And that parasympathetic nervous system is what also causes side effects and also can cause a decrease of heart rate, because parasympathetic decreases the heart rate. Now, this is the classic teaching. The classic teaching is that you're going to have high blood pressure and you're going to have bradycardia. And then you're also going to have other symptoms because of the parasympathetic above the level of lesion that can be activated. That will give you the headache, the flushing, the increased secretions, and the congestion. And the sympathetic nervous system will give you blurred vision and the anxiety and some other issues. If only it was that simple, because it is not, right? We think that it's the parasympathetic and sympathetic nervous system, but it's not that simple. If it were, for example, every time a person had dysreflexia, they would have the same signs and symptoms, but they do not. We now know that the level of the injury, or the level of, more importantly, of what's causing the problem, will alter the blood pressure elevation, will alter the symptoms. It is much more complex than just the sympathetic and parasympathetic nervous system reacting. In fact, there are some people who become dysreflexic and have no symptoms at all. Dr. Linsenmeyer, who I've had the pleasure of working with for the last 35 years, who's just retiring now, first described autonomic dysreflexia in men from their bladders. And then we found it in bowel management. So this definitely occurs where people's blood pressures are skyrocketing and they may not even know. Now, I think one of the important things to think about is, okay, this seems like a really important topic. How common is AD? And if we were together or I had an audience response system, I would be asking you to take a guess at what you think the number would be. And I don't know if you can speak, but I would tell you that most people say, oh, maybe about an episode every other day. Well, the answer really is 400 episodes a month. What people think, oh, that hardly occurs, may be occurring a lot more. How do we know this? There are studies, a number of studies have looked at this, and they kept a constant blood pressure monitor on for 24 hours or 48 hours and found in one study an average of 13 episodes of AD per day. That's a lot of episodes. And what is the impact of this? Right? So who cares if you have AD if it doesn't cause any problems? But does it? And I think that it's important to recognize that there really may be long-term complications of AD. We know that people with tetraplegia have a much higher percentage of cardiovascular disease. People with tetraplegia are 5 times as likely to have strokes, 44 times higher chance of coronary artery disease and cardiovascular disease. This is a real problem. As you know, that for many people with spinal cord injury, cardiovascular disease is probably the #2 cause of death, #1 being respiratory. So it really can be a complex issue. There are immunological issues. It seems that the more often that the blood pressure is elevated, this can increase chances of kidney disease and thereby urinary tract infections. And the costs. Just going to the ER, I imagine I'm speaking to an audience that very well knows what the costs of going to the ER may be. And in many cases, the ER physicians may not exactly be sure what the cause of the AD was, and then therefore you're admitted. And the admission, you've seen the bills. They are very expensive. So how do you treat dysreflexia? And I'm keeping an eye on the time. And I'm going to try to go through 8 steps that I think are critically important. The first step is to recognize you're dysreflexic. You only know how to take out the bag of tricks or what you need to do if you recognize that you're dysreflexic, or the people around you have to recognize that they're dysreflexic. The first step is sit up. Sitting up, it's called hydrostatic pressure. By sitting up, you're going to lower your blood pressure a little bit. By a lot? No. But if it lowers it by 10 millimeters of mercury, well, then that's pretty good. That's a good start. And it's interesting because in most hospitals, when the person's blood pressure is severely elevated, they may lie them down. But in spinal cord injury, you want to let them know, sit me up, please. The next thing is loosen restrictive clothing. How many times I can tell you that all you need to do is loosen the shoelaces, take off the shoes or sneakers, and you find that something, either the shoelace was too tight or something was stuck in the shoe that you didn't even notice. And you just take out that rock from the shoe and the dysreflexia goes away. Sometimes if you have a leg bag, the leg bag may be too tight. The stockings may be too tight. You never know. So I've sometimes where the toe was bent and that caused the dysreflexia. So being able to look at all of these is very important in terms of being able to treat it. A very common question people ask me is, how often should you check the blood pressure? And my answer is 5 minutes. The slide says 2 to 5, but I'll explain to you why 5 minutes in just a couple of slides. But retaking the blood pressure every 30 seconds is just going to drive everyone's blood pressure up even higher. Because if you're looking for the source, once you find the source, the blood pressure will go down. But taking time to take the blood pressure every 30 seconds is going to interfere with your finding the source. And if you're using medications, the medications don't work that fast. So you want to get the blood pressure down, but you first want to find the source and not spend the time taking the blood pressure consistently. Now I would say go for the gold. You've sat the individual up, you've loosened the clothes, you go for the gold. And the gold is the bladder. 80%, or usually about 80% of all cases of dysrefluxia are due to the bladder being filled. So therefore, try to empty the bladder. If the person has an indwelling catheter in, check for kinks, because sometimes it could just be twisted, and that's causing the problem. You can irrigate with normal saline, but please make sure that it's room temperature, not cold water. Cold water causes the bladder to contract very forcefully, so you don't want to use cold water. If you happen to have a water bottle that was just taken out of the refrigerator, that is not the water that should be used. If you happen to have Urojets, which is a xylocaine-filled syringe, then feel free to use it. But don't waste 10 minutes looking for it if you can't find it. If the person doesn't have a catheter in, then simply catheterize. Now, if there is a catheter in place and seems to be working okay, and you want to see if it is the bladder, in fact, as the source, what you can do is you can inject xylocaine into the bladder, right? You inject xylocaine into the bladder. I don't know if you've ever heard about this. We can talk about it. You irrigate it into the bladder. You clamp it for just a minute. And if the symptoms go away, you know that it's the bladder as the source of the problem. And then as mentioned below, if no catheter, if you have lidocaine gel, use it. If not, just catheterize the patient. Next is medication. Now, there are a lot of different medications that are being used around the world, and I'll show you that in a minute. My personal preference is nitropaste. I usually, if the person's blood pressure is only 120, I'm not going to rush to using nitropaste. If, however, the blood pressure is above 150, then I would recommend using some pharmacologic intervention. If it's lower than that, you still have some time, look for the sources, and then give the medications. But you have to remember that every time you give a medication, it's going to lower the blood pressure as well. This was a recent article which looked around the world at what medications were being used. And in the United States, 98% of US physicians are using nitropaste for dysrefluxia. Outside the United States, though, much fewer because it's not available. There are some patients of mine who have nitropaste at home, and if I trust them and they know how to use it, we'll be able to utilize nitropaste in their home environment. If nitropaste, you can't use nitropaste, and there are a number of reasons you can't use it, then you can use hydralazine, which is a pill, or nifedipine, also called Procardia, which you can either swallow, or what I do is I recommend to chew and swallow. By chewing it, you release the medication and it's absorbed much faster. Truth is, nifedipine works much faster than nitropaste does, and so does hydralazine. But I truly recommend the nitrate for a couple of reasons, and I'll show you now in a moment why. So the benefit of the nitrates and nitropaste is that it takes time, and the way that it works, I don't know if you're all familiar with it, it's a paste, and you put the paste onto a pad, a little piece of paper, and it'll give you how many inches. You do it by inches, a ½ inch, 1 inch. I usually recommend starting at 1 inch, and then you put the nitropaste onto the individual. It takes about 10 minutes for the nitropaste to work. We could talk about how long, but that's the average of how long it'll take for nitropaste to work. The Procardia will work much faster. But here's the big benefit of using the nitropaste. When I find the source of the dysrefluxia, I wipe the paste off. And when you wipe the paste off, the blood pressure effect will go away soon. But if you gave the pill, it'll stay in the system for quite some time. So now if their resting blood pressure is 90/60, they become dysreflexic. Their blood pressure is much higher. You give them the pill and then you find the source 5 minutes later, their blood pressure will plummet and may go down to 70, and they may become very symptomatic. So that's why I prefer to use the nitropaste. But again, everybody has a different way of doing it. I recommend putting it on the forehead. Many people put it on the chest wall. Very similar to nitropaste is also used for people with chest pain. The reason I use it on the forehead is not because I believe it works any better than putting it on the chest wall. It's that one time I had a patient where the person got dressed again without recognizing that they had the nitro paste on. And then after the dysreflexia was over, they ended up fainting because their blood pressure became too low. One will never forget that there's nitro paste on their forehead because you feel it and you realize that it looks awkward. So you will always remember to wipe it off. But it will work anywhere above the level of the injury. At that point, if the blood pressure doesn't go down, then I'm going to look for the bowels. I strongly always recommend that before you're going to check the bowels, you always use lidocaine gel first. And the recommendation is that you put lidocaine jelly by the rectal area. So the person's sitting up, you lay them down, put lidocaine jelly, sit them back up, wait 5 minutes, and then you can do the rectal examination to see if there's a lot of stool below. The reason is because whenever you're going to do the rectal stimulation, and by the way, I've always used medication as well, whether it's nitropaste or Procardia. You're always going to elevate the blood pressure by doing the rectal examination. Sometimes giving an enema or suppositories are needed, but you have to get rid of the stool and the source. If it's neither the bladder and it's not the bowels, then you have to continue to look for what any other cause could be. Now, I want to mention a couple of other things that I'm not sure if I have the slides here for it, so I'll mention it. One is a lot of people ask if nitropaste is the most common, how long after you wipe it off does nitropaste last? And the answer is only about a few minutes. In most cases, 2 minutes. So therefore, at 5 minutes, after you wipe it off, the blood pressure effects of the nitropaste should go away. It doesn't have much lingering effect afterwards. The other most common question that people ask me about nitropaste is that if you're also taking Viagra or a medication like that, it is an absolute contraindication to take Viagra and nitropaste at the same time or even close together. So how do you deal with that? So the way that I deal with it is, if it's a person who's taking Viagra, I let them know that they cannot use the nitropaste within 24 hours of having taken a Viagra. If you use one of the longer acting medications like Cialis, then it's longer time period. But it's 24 hours for Viagra. And in those cases, I'll just tell them don't use nitropaste and just use one of the other pharmacological treatments instead of using that. Now, I mentioned before that there's no doubt that digital stimulation, anytime you're going to do a rectal examination, you're going to have elevation of blood pressure. This is extremely common. Every time you have a bowel program, in truth, you may be getting dysreflexic. I don't want to say everybody, but most people. This is a study that I did, and I realize hopefully none of you were part of this study, which was where I looked at everybody's blood pressures before their bowel program, during their bowel program, and after their bowel program. And what we found is a significant rise. Almost every single person, I think every person in this study became dysreflexic if their level of injury was above T6. Now, that doesn't mean that therefore this is severe for everybody, because having a bowel movement will increase people's blood pressures. But if your blood pressure is going up, as it says on that blood pressure machine, to 203/114, that becomes a little bit more significant. So in those cases, what do you do? Because the constant dysreflexia will make you feel really bad. It's a source of decreased quality of life. So many people will recommend using lidocaine, just like I mentioned before, using lidocaine before doing the anal exam, of using lidocaine before the bowel program. So does this work? And the truth is, I don't think so. There's debate in the literature, but there was a very interesting study that looked at this, where what they did is is that they gave people who were dysreflexic during their bowel program, and they pre-treated them with lidocaine. And they waited a few minutes, and then they did their routine bowel program. Now, the patients, the individuals, did not know whether they were using lidocaine or some other medication, placebo. It could have just been, some other gel. And what's fascinating is that 100% of the people had dysreflexia. But that's no surprise because these were people that were dysreflexic to begin with. But in the treated group with lidocaine, their bowel programs took longer to complete than the people that did not have lidocaine. And the lidocaine was associated with even a higher blood pressure and a greater amount of dysreflexia than the people who did not have the lidocaine. So if you want, we can discuss why this case may be and what to do in these situations, but it really is fascinating that sometimes this is why we study things, because common sense may, or what we think may not really be fact. Now, I want to spend the last couple of minutes on this, and I'm keeping a close eye on the time. I'm coming up to my half hour. And I just wanted to talk a little bit about some fascinating research that's been taking place about the use of spinal stimulation, specifically how it relates to autonomic dysreflexia. I will tell you that if you scour the literature, there are very few studies on spinal stimulation. Spinal stimulation includes two different types. The first is epidural spinal cord stimulation. This is where it's a surgical procedure and electrodes are placed into and around the spinal cord to be able to cause stimulation of this cord. The second type is called transcutaneous, where you stimulate across the skin. There's no surgery required. And there seems to be evidence that spinal cord stimulation can promote motor and autonomic recovery following spinal cord injury. So let me show you a little bit about some of the work that's been done. Very few papers. This is one paper that looked at epidural implant. And the way that they stimulated dysreflexia was by doing a rectal examination, by digital interrectal stimulations, and they did it with and without electrical stimulation. To let you see what's going on here, hopefully you can see my pointer, without electrical stimulation, when the digital rectal was done, you can see that the blood pressure goes to 140 to 160, a significant elevation from about 110 to 120. However, when the stimulation is on, a person's blood pressure does not go up. It prevents autonomic dysreflexia even when you're doing the stimulation to cause the elevation of blood pressure. So that's with epidural implant, albeit only on 3 patients. So this isn't a paradigm shift in medicine overall. This is a study that was done only on 1 patient, very high level injury, but this is transcutaneous. And here what they did is, again, they caused the rectal stimulation, and you could see the blood pressure go up significantly. Yet, when you use the stimulation, the blood pressure does not change at all. Again, this prevents and interrupts autonomic dysreflexia by about 82%. In this case, what they did is that they did here's the blood pressure, they do the digital stimulation, no electrical stimulation, the blood pressure goes up, you now start electrical stimulation, and the blood pressure comes back down. Almost regulating blood pressure, prevention and regulation of blood pressure. So this is new. I'm sure not many people, we're doing some work on it at Kessler, but there are a number of centers around the world doing some of this work, and hopefully we'll know more about this in the near future. So in my last minute that I have, I just want to give you the take-home messages. Autonomic dysreflexia is something serious, but it's also very common, 400 times a month in people that are very at risk for it. But we have tools to address it. Knowledge of what happens is important. knowing how to deal with it is important, and we went through the steps. Future treatments may be very exciting. Hopefully now you feel armed to identify dysreflexia in yourself, in your family members, in people around you. Consider its role in many different clinical presentations and address it as much as possible and as quickly as possible. So thank you so much. And I really appreciate the invitation, the opportunity to speak with you. And it is 3:45 on the dot. So John, I hopefully met at least that requirement of being finished by 3:45 to answer.
Doctor, you landed the plane right on time. That's amazing, and with such great information. I've learned a heck of a lot, and as I said, I've been in this game for 32 years, and I learned more in the last half an hour than I did in all of those years. And so, I want to thank you for the presentation. And I guess Barry, at this point, do we want to open things up? If people have a question, maybe unmute yourself and raise your hand and see what's out there.
You got a question from Anita Kaiser there, John?
Okay, Anita, please.
Hi, Dr. Kirschblom. Thanks so much for such an informative and really important talk. I have a couple of questions. So my first one is, I've been really interested in, I have a spinal cord injury for about 28 years now, C6-7 Asia A. It took me a while to get an understanding about AD and symptoms. And what I've found over the years is I will experience different symptoms depending on what the noxious stimulus is.
Exactly.
And I was always interested in finding out if there have been any studies, I never looked at it, to see if anyone's actually tried to characterize it, to see, does everybody experience, let's say, goosebumps if the stimulus is related to a full bladder? Or does everyone experience sweating or a headache if it's related to bowel? So has there been any attempts to try and characterize it? And is there anything that's similar across the board, or is it just really individualized?
So Anita, thank you so much for the question. And it's a multifold answer. So number one, yes, I mentioned in one of my slides that it's not so simple. It seems to be what the noxious stimulus may be and the level of the innervation of that stimulus. So your bladder is innervated by certain levels. Your toes are innervated by a different level. Dr. Solinsky, the person I mentioned before, did excellent work where he's looking at different noxious stimuli. For example, comparing putting someone's foot into an ice bucket, which is going to cause dysreflexia, and then also filling the bladder, and that's going to cause dysreflexia, and clearly seeing the different symptoms that they may cause. I think the second thing is, and I had the opportunity to publish a paper a couple of years ago, where I established that I believe that part of the reason for some of the difference in symptoms is not only the systolic blood pressure, but the effect of the diastolic pressure. And sometimes everyone's always looking at that high number, but that low number may be responsible for more symptoms than others. So we don't know yet. We know that everyone is a little different. In people that are in your own individual thing, the different levels of the cause and the site of the noxious stimulus coming from will give different symptoms. And that's currently being worked on to try to figure out how to really map those things specifically.
Terrific.
Sorry, and I had another question. So I was really interested in what you were talking about in terms of silent AD. I have noticed that there's instances where I'm very attuned to my blood pressure, that I can actually feel it rise to the point that when I was actually in labor with my daughter, I knew when I was getting a contraction before it would show up on the monitor. And I can feel very slight changes in blood pressure. However, I've also noticed where I don't feel my blood pressure go up, but I do experience symptoms of AD, like the sweating and stuff. Is that what you would classify as silent AD, where you're getting symptoms, but not, like I never actually checked my blood pressure. So possibly it did go up without me feeling it, but I find that hard to believe. But
Yeah, so it's very interesting. So great, really great questions, and your experience really fits in perfectly. Some people, when we say silent, it doesn't mean that there's no symptoms at all. It means that people write it off to saying, it's probably not that. And then when they check their blood pressure, they realize, oh my gosh, because usually they check their blood pressure when they have the severe headache. But then they also have symptoms, well, I just got a little tingling in my head or whatever. That could be dysreflexia too. So dialent dysreflexia doesn't mean no symptoms at all. It means it's not symptoms that you usually relate to the fact that you're having dysreflexia. And the important thing I would recommend is check your blood pressure. And if it is dysreflexic, find the source, and there may be ways to prevent it in the future.
great, thanks very much.
Great questions, Anita. How about John Chernesky? The floor is yours.
Thanks, Steve. Again, I just want to echo what Anita said. It was an amazing presentation. You covered so many topics in such an easy to understand way. So congratulations. It was a really great talk. I want to touch on a couple of quick things. Anita mentioned there the sweating, which I don't know if I remember hearing in your presentation, which is a sign that I often see. And it's funny, the way autonomic dysreflexia was described to me, it's kind of like an elevated fight or flight response where your body's kind of, you're getting that stimulus and it's like the old saber-toothed tiger jumps out of the jungle and you got to be ready to go, right? So your body's just, heart rate goes up, blood pressure, or heart rate drops, blood pressure elevates, all that sort of stuff. And what I've found for me, and I think a few other people that I've spoken to, is it's not necessarily blurred vision that you get. You almost get like tunnel vision, like focused vision, like almost like you're about to get into a fight. You're very much focused on what's directly in front of you, as well as sort of your mental focus. Like for me, I often get it with needing to empty my bladder, and so all I can think about is I got to get to a bathroom. I got to get this bladder emptied, and I've got tunnel vision, and that's the one thing. So I noticed you mentioned some confusion or blurred vision, but for me it's more of a mental focusing and a narrowed vision. The other big one that I noticed too is, I guess, part of that fight or flight response. All your blood's going to the large muscle groups to try to get ready to fight off or run away. And my fingers, my toes, my hands, my nose all get cold. It's like those peripheral vessels are starting to contract to make sure the blood's getting to the heart, the brain, and the big muscles to fight. Whereas your fingers and toes and nose aren't as important at that point. So those are some things that I've noticed. The other one I wanted to point out, you mentioned some of the health issues related to ongoing dysreflexia. And I was really startled by a paper that came out, I think it was out of the Krasiakov lab, around that pendulum of people with spinal cord injury getting dysreflexia, where your blood pressure is elevating multiple times per day, but having chronic low blood pressure. So your blood pressure, they called it the pendulum, and that blood pressure where it's going really high and really low, really high and really low. And as you can imagine, that's wreaking havoc on your blood vessels and your entire sort of circulatory system, but it also has a massive effect on cognitive function because your blood vessels in your brain are being expanded and contracted, expanded and contracted. And so, that's my excuse for why I'm not as bright as I used to be. It's all to do with blood pressure bouncing up and down. So something to be aware of. If you think that dysreflexia is nothing big to worry about, over a long period of time, your blood pressure bouncing up and down can have a lot of really bad effects, not just on your overall health, but also your cognitive function.
Yeah, John, a couple of things you mentioned, I think really important. So some people have some sweating, some people have literally dripping wet when they're dysreflexic. That is definitely due to the facial and upper extremity sweating from the sympathetic nervous system, as you said perfectly, fight and flight, which is also why you get blurred vision, because you develop pupil dilatation from it. The pendulum, I think, is a critically important issue. One of the first of all, Andrei Krasnikov is one of the world's leaders of autonomic dysfunction, a wonderful person. He's out in Canada, really amazing individual, and the work that he and his lab have done has been amazing. And we've also done work where we've looked at trying to maintain people's blood pressure, because this pendulum, if you're low blood pressure, you give medications to raise it. But then if you become dysreflexic, now you're pushing yourself over the threshold where you're now dysreflexic. And that's a real problem. And there are studies that show that people that have chronic hypotension, low blood pressure, cognitively they're not in tune. No doubt that when my blood pressure is no good and I can sense it, I'll take some chocolate, I'll take a cup of coffee. And what am I doing? I'm taking caffeine that's causing vasoconstriction. I'm raising my blood pressure. So this is very, very common. Now, with the use of electrical stimulation, and Dr. Kroskov's lab have done this, our lab has done this. We presented just a few weeks ago in one of our studies where we're looking to regulate blood pressure. I mentioned in the studies here about just regulating dysreflexia, but what people are really looking to is regulating blood pressure. And we're putting in closed loop systems, meaning something that's in your body that will regulate your blood pressure. And when it's low, we'll raise it. When it's high, we'll lower it. We'll regulate it, keeping it so that it's not going back and forth, so that you're in a steady state position. Just like people before a spinal cord injury, what it's supposed to do as well. So all the symptoms you see really are real life issues. And thank you very much for bringing it to life in what you see.
Great questions, John. Terrific points. Now, how about let's go to Joseph DiGiorgio. You have a question for Dr. Kirschblum?
I actually did. However, the last 4 sentences answered the question I was going to ask about using spinal stimulation to regulate blood pressure when you do get AD and go low. So I guess my only question would be, are there current studies active that are looking at that? Or are these future planned studies to use that closed loop system to regulate the blood pressure?
Ongoing. So very clear ongoing. There's a couple of different trials specifically. We have one by us, and I'm not in any way marketing for us. There are a couple of great labs around the world that's doing this. Andrei Krosakov is doing this. Cortine's lab in Switzerland is doing this. A number of labs, Louisville, Kessler, we're working in collaboration with them. But Minnesota has something. So and hopefully the field will continue to collate, get together, put our data together to find what would be the best for people in the future.
Perfect. Thank you, Doctor.
Are there any other questions out there? Please don't hesitate to ask.
Well, I wanted to make sure. Barry, of course, has to get a question.
Yes.
I just, Dr. Kirschblum, I want to follow up what John was saying. It's almost like a anecdotal myth in our community that hasn't really been answered, but some of it have actually claimed that some of these periodic episodes of AD are almost like mini strokes. And then John's reference to cognitive impairment over time. I just wondered, could you just go a little further on that? I mean, is there long-term effects cognitively? Has that been proven with chronic AD?
So that's a really great question. And I will tell you that the easiest answer for me to say is the less the fact, the greater the opinion. There is no strong evidence that says that just because you've had episodes of dysreflexia that will occur. And the reason I say that is that many people are also on medications. If you have a chronic spinal cord injury, you're on medications that may cause some cognitive decline as well. And I'm not blaming the medications. Obviously, we all need to take medications. Medications have side effects. So I don't want to blame it on that. Obviously, if you have a stroke because of it, then that is yes. But I can't say for sure that it's necessary due to that.
Thanks.
What I would ask is any questions that people may have, Barry or John, if you can collect them. I need to be somewhere at 4 o'clock. So I so apologize if I have to run, but I'm so appreciative for the invitation and getting to meet. Wow, I was told there may be only a couple of people on, so this was really a great group. So thank you so much. And John, I'm always here for you, anything I can do. And Barry and the group, thank you so much for having me.
Thank you.
Dr. Kirschblum, thank you so much for such an informative presentation. You're one of a kind, and we were so happy that you were able to join us today.
My pleasure.
Barry, I will leave it to you now. If you have some housekeeping as far as our next Connections meeting, if you have any other parting words.
Just thank you, Doctor. That was amazing. John, thank you so much for hosting this event. I just ask people to go to the NASCIC website and to learn more about our upcoming informational webinars. There is a SCI graduate workshop. So those of you who have taken the SCI Research Advocacy course, as a graduate, you're eligible to attend the next Wednesday at the same time at 3 p.m. Eastern. So if you haven't taken the course, go take it. and then you're a graduate and you can attend. And as well, our SCI Connections are on a quarterly basis. Our next informative one, we do a year-end review in December, but then early in the first quarter, we will do another SCI Connections. So stay tuned to be announced to what the topic will be. But John, on behalf of NASCIC and our community, I want to thank you so much for giving your time today and helping us carry this forward. It was a great webinar. And back to what you said, and what the doctor said, John, is feel free in the chat right now to enter any questions that you have. I know the doctor, John, I think you would agree, he would endeavor to answer those questions at some point in the near future.
Without question, he will get back to you. If you pose the questions, we will bring it to him and he will email or get back to us without question.
And last thing is that this webinar will be made available to all who registered today, and eventually it'll be posted online on our NASCIC website.
Thanks, everyone. Have a great afternoon.